I'm Joe Purita. I'm an orthopedic surgeon. I'm also a stem cell person. I've been doing stem cells for many years now, and we're going to talk today about stem cells. And this is a new field in all of medicine, not just orthopedics. But in orthopedics, I think we probably have gone a little further than most specialties because of the fact that it's something that's we can put the cells there fairly easily, and we can retain the cells there. So this is what I call the Holy Trinity. And we can see here that we have adult stem cells, we have a scaffold, and we have growth factors. I'm also a gardener, and I want you to think of this as like planting a garden. The stem cells are the seeds. The scaffold, such as fat, is the soil, and the growth factors are the fertilizers. Now, there's no one in this room who's ever gotten a patient better. I hate to tell you. It's not we as doctors that get patients better. The cells get the patients better, not us. You do surgery, the cells have to heal that wound. So whatever you do, you can guide the cells along. It's like we're flying little drones or something, but we don't get the patients better. The cells get the patients better. And that's the whole idea of stem cell therapy. We're using cells to get things better, the way nature intended to. Now, we need to talk about platelet-rich plasma, okay? Now, like everything we're going to talk about in this whole conference, the more you know, the more you don't know. So hopefully at the end of my talk, you're going to know a lot more information. But because you know a lot more information, there's going to be a lot more things you don't really know about. And every day, my list of not knowing things gets bigger and bigger. Anyway, this is what a normal platelet count looks like if we did a smear of blood. And that's what we call a platelet-rich plasma, where we have a lot more in the way of platelets. And we can see it there. We have a laser? Oh, good. We do have a laser pointer here. All right, now this is what we call the growth factors, okay? This is the power of platelets. Well, we know that platelets can cause a fibrin clot, no question about it. But we have all these various growth factors here. We have IGF-1. What is that? Insulin growth factor 1. VEGF, vascular endothelial growth factor. Think of stem cells as an approaching army. And like any army, it needs supply lines. Vascular endothelial growth factor can help supply those guidelines because it can put out a vascular network that the stem cells can utilize. Now, what's in a PRP? Well, we have platelets, we have neutrophils, we have fibroblasts, we have endothelial cells, we have keratinocytes, and one of my favorite guys right here, very small embryonic-like stem cells, which is not that much in the literature yet. It's a relatively new cutting edge of the cutting edge topic. Now, what's in a good PRP product? Well, we have a platelet of 1.5 to 3 million microliters, and that's very important because that's what helps establish an angiogenesis, okay? And again, we have these very small embryonic-like cells. Now, here's some important things. There's a lot of controversy when we talk about PRP. And we look at some scientific studies, and we see that the PRP didn't work any better than placebo. Other studies, it shows it works wonderfully. There's no good definition of what a PRP is. But one thing I'm going to tell you that's very important, you have to have white blood cells, basically monocytes in your PRP, because they produce these growth factors, SDF1 alpha, or also called CXCL12. That is what calls stem cells to the area. So if you're going to use a PRP product that has no stem cells in it, guess what? You're going to have some problems because you're not going to have a good effect. Here's a great study, okay? 2012, Hayes and Fuchs. What they showed here was when they had the monocytes, they got very good mobilization of hematopoietic stem cells with no macrophages there, almost nothing. So important. You have to have those macrophages there to really get a good result. Now, one thing you should know, what's the difference between vasculogenesis and angiogenesis? We kind of throw these terms around, but guess what? They really are quite different and quite important, okay? Vasculogenesis is where we have no blood supply. We're now establishing a new blood supply. Angiogenesis basically ramps up the pre-existing blood supply. And this is sometimes important in the field of cancer, you know, where they can sometimes, you get angiogenesis, and some of these medicines that they use for anti-cancer medicines are anti-angiogenic. So it's something that you need to know. Now, what are cytokines? We're going to talk a little bit about cytokines. The best way I can describe cytokines is basically right here, my cell phone. This is how the cells communicate with each other. by a system of using various growth factors. Now, what do cytokines do? Basically, cytokines go to the cell membrane of the stem cell. The cell membrane is the eyes and ears of the cell. It interacts with the environment called the stem cell niche or the extracellular matrix. So important. So you want to do anything you can to get this membrane in good condition because that will make the chance of success much higher. So sometimes if your patient has a poor diet and his cell membrane is very high in omega-6 fatty acids, it's not going to work so well. That's why you want to start giving your patients omega-3s. But we'll talk about that in my next talk. Now, once we have those activation of the cell membrane, we start getting various biochemical compounds that are being produced, and we start getting some division of cells, and it's a whole litany of things that are going on. Now, this is what the PRP looks like right here, basically. We have this buffy coat. We don't really want the red blood cells. We discard most of that. And this is what we call platelet-poor plasma. Now, there's many different ways of producing a PRP. You just need to make sure that the system that you're using is one that's giving you a high count of platelets, because a low count of platelets is not going to be very well for you. Now, conditions that we treat with PRP, well, disorders of the shoulder, tendinitis works very well, muscle tears, meniscus tears that are relatively small, mild to moderate degenerative arthritis. I have to emphasize to you when I say mild to moderate. The bone-on-bone arthritis is not going to respond to PRP alone. It will get better somewhat, but PRP alone is not going to do the trick for you. Now, there's a new classification of PRP from Dr. Mishra, who's at Stanford. Now, he has 4 different types. He has PRP with increased white blood cells, PRP with minimal white blood cells, PRP that's activated, PRP that's not activated, and then platelet concentrations. But they're missing the boat here on one very important aspect, and I call this the number 5 type. This is basically a light activated PRP. In our office, we have every PRP that we do is put into a special LED light. And that LED light affects the white blood cells significantly. It makes them become anti-inflammatory instead of inflammatory. They produce interleukin antagonist. So once you do that, then the white blood cells are important because we need them for stem cell motility, but they're also helping us produce anti-inflammatories. So type 5 is what you need to get. I'm going to write a paper about that, and that should be coming out in a little while. Now, what's going to be the next PRP? Well, I don't know if I'm going to say it's the next PRP, but it's another alternative. Protease inhibitors, okay, metalloprotease inhibitors. Metalloproteases are something that like to destroy cartilage and things like that. So this is something that's found in your blood, but the trick is you have to concentrate it. It's found in fairly high concentrations, 6 milligrams per milliliter. And it basically inhibits any type of, the A2M, I should say, inhibits any type of inflammatory process by and large. I've done a number of cases with it. It seems to work okay. One thing I'm going to tell you, any of you that take care of wounds, there's a certain number of wounds, about 35% of them, that are what they call metalloprotease positive. PRP won't work on that. This stuff will. But for regular orthopedics, it's an adjunct. It's not my main weapon by any means. Now we need to get into the talk of stem cells, all right? So, interestingly enough, without stem cells, we would live a day or two, and then we would perish. It's essential to have these things do their thing, as the old saying goes. Now, adult stem cells can be a couple different types. Most cells are what we call multipotent, okay? They can differentiate into a subset of cell types. There are some pluripotent cells. Pluripotent means that they can do almost anything. Now, those are sort of the embryonic type cells. Again, most of our adult cells are multipotent, okay? Now, they also can exhibit plasticity, these cells. Now, what type of cells exist? Well, we have embryonic, we have mesenchymal, hematopoietic, IPS, other very more specialized type of cells, and then again, my buddy down here, very small embryonic-like stem cells. Now, let's talk about the embryonic cells. In the United States, the FDA has significantly inhibited us from using these cells, okay? There's a lot of ethical issues with these cells, but we're all scientists here, so let's put the ethics aside. We don't need to talk about ethics, we need to talk about science. There are very specific reasons why we don't like these cells, and these are they. First of all, they will, the patient can inherit any potential disease that embryo may have. Secondly, that these cells can grow unchecked. They can form a teratoma. One of the definitions of an embryonic stem cell is when put into an organism, it typically will form a tumor, okay? There's certain immunologic factors. These cells are not immune privileged. These cells basically can attack the body of graft versus host disease. You'll have to then give the patient immunosuppressants. So right now with our technology, we're at a dead end with these cells. There are some good potential with them down the road, but the ethical issues aside, right now we're not getting much good progress with these. Now, iPS cells, okay, these are cells that are produced from adult cells which are manipulated into becoming a stem cell by either enzymatic or viral means, okay? The problem is when we start using the viral means, it can turn on something called an oncogene. When you hear the word onco, it's oncology. It means it's turning into cancer. Now, I showed a picture here of Dolly the sheep. Dolly the sheep was cloned. Dolly is not an iPS cell, but there is a good correlation here. What did Dolly die from? Dolly died of old age at a young age because Dolly's DNA was old, okay? So basically, one of the problems we have with stem cells is the DNA. We have aged DNA. Look at the stem cell telomere, and the telomere is the end of the DNA in an embryonic cell. Look at how long it is. Look at the same thing in an adult stem cell. The longer the telomere, the more efficient that cell works. So the real key in really stem cells is we have to somehow or other figure out how to get those telomeres back in place. We have some ideas, and we know there's some certain substances that will stimulate telomerase, but right now we're not sure. But that's one of the problems we have. Now, here's another thing about the cancer, okay? New Scientist, July of 2015. They had to stop a study because they found, and this was being done for blindness, that some of these cells were going towards cancer lines. That's a pretty serious problem. And there's been no evidence of any use of adult stem cells going to cancer so far. There's not one documented report in the literature that I'm aware of that shows that. So that's an important thing to realize. So right now, iPS cells, they may be the darling of certain academic centers. Other academic centers are condemning them. Again, we need to have more technology on these cells. Now, somatic nuclear transfer cells. Basically, this is cloning, okay? A patient of mine who's a very, very wealthy individual who's actually involved in this in the Caribbean. What he does is he takes the nucleus out of an unfertilized egg, inserts his own nucleus into that cell. Now, interestingly enough, what happens is when they do that, it causes his DNA to go back in age. It actually lengthens his telomeres. So that's something that's very, very interesting to say the least, in that we're getting maybe that pristine DNA. But the problem is, this is cloning. The good news so far is they can only get the cells to go to a couple steps. They can't get over that jump of making it into a person, thank God. I mean, I don't think we really want to start cloning people, but, you know, that's down the road perhaps. So one of my favorites, again, is a very small embryonic-like stem cell. There's a bunch of different names for these cells. These are found in your body, and guess what? They're pluripotent, meaning they can form almost any type of tissue. They may eliminate the need to culture cells, okay? They're nearly totipotent, okay? That's like a fertilized egg, essentially. And they have very distinct surface markers. Now, interesting about these cells, there's a proprietary formula that will dramatically increase their numbers. Okay, they typically are found in good numbers in the body, but they're not activated, okay? One of the common threads in all the studies on these cells is they get activated by stress. And one of the things that we typically do is we put these cells a few hours in a refrigerator at 4 degrees centigrade. That seems to turn these cells on, and that's what makes them do some interesting things. But look at also what's interesting about these cells. Telomerase, remember the telomeres. They make telomerase, okay? The only cells we know that make telomerase are basically cancer cells, that's why they're immortal, and your reproductive cells. That's why your children are always born young, because the DNA has never been aged. So these cells make telomerase. Another very interesting fact about these cells, which will really kind of put them in perspective, we think this is how acupuncture works. We know, for instance, that acupuncture corresponds to some of these things called Bonghand channels. And we know when you stimulate these channels, these cells are found in these channels. So we're thinking that the ancient Chinese were onto something thousands of years ago. They were basically the first stem cell therapist. They were stimulating these stem cells in these channels, and this is what they look like right here. And you can see they're staining the same as a stain of an embryonic stem cell. So we think that embryonic stem cells, or I should say these very small embryonic-like stem cells, are responsible for the effects of the acupuncture. Now, again, this is some more of the tough science about it, but they're very small in nature, so that means they very well may cross the blood-brain barrier, which is good for some of the mental type things that we deal with and injuries that we deal with. These are called the Yamanaka factors. These are found in embryonic cells, but they're also found in these cells also. Now, what's interesting about these cells is that they're pluripotent, and they have different markers at different times. One time they can be one type of cell going to one type of lineage, and then later on they can go to another type of lineage. And certain things turn them on. One pearl I'm going to give you today, and it's also being found in the orthopedic literature now. We're now finding that parathyroid hormone is very good for orthopedic injuries. It helps heal. And we think that that's because these cells have a certain marker to the parathyroid hormone. So you might want to consider putting your patients on some parathyroid hormone, and that may very well help. Now, what other effects do we find with these cells? Well, we see that this is the DNA of a normal adult cell. This is the DNA of these cells. The wider apart that DNA is, the more potential it has of actually undergoing regeneration, etc. Now, again, parathyroid hormone. The trick is, even though I'm telling you this, you're not really going to figure it out completely, because the trick is when, how, and what dosage to use. And this is kind of proprietary that I'm under an NDA with for certain companies. But again, we see some literature. Basically, we see parathyroid hormone is chondroregenerative for injury-induced osteoarthritis. So again, something to bear in mind. That may be that we want to use something like Forteo to treat osteoarthritis. Excuse me. Now, another interesting thing about these cells, we think that these cells may be very good for anti-aging, okay? And if you go and read in the literature how you go ahead and give mice, excuse me, let me get a glass of water here. You can read about in the literature how when we, excuse me, give a young mouse blood to an old mice, the mouse has a lot of the factors that are with aging to go back in nature. Now, basically, we've already done a couple of cases. We've taken cells. Now, they have to have the same blood type from a granddaughter, giving them back to a grandmother. And we've had some pretty profound things. We think also these cells may be extremely important because of their parathyroid hormone marker on them for osteoporosis. We're actually doing a study right now to see how these work with osteoporosis. My good friend in Australia, Dr. Bill Paspalaris, has had superb results in treating osteoporosis with these cells. Now, what kind of cells can we use in the office? We have hematopoietic cells, bone marrow cells, fat cells, and these very small embryonic-like cells. Now, mesenchymal cells are not the kings that everybody thinks they are. When you think about, oh, my God, the mesenchymal cells are the real kings. No, they're not. They may not even be considered a stem cell, in all honesty, with the newest thinking. Now, basically, we must realize that the most important thing about these cells is they secrete massive levels of bioactive agents that are immune modulatory. In other words, they change that environment. Now, we used to call these MSCs, mesenchymal stem cells, but now what we think we should call them is medicinal signaling cells. They basically are drugstores. They make a whole host of biochemicals that affect the stem cell niche. Now, the thinking of Dr. Arnie Kaplan, that all mesenchymal stem cells are basically periocytes. They're found in all the blood vessels. So wherever you have a blood vessel, these little guys are hidden there. And what Dr. Kaplan said is he said, listen, when you have an injury, this periocyte becomes a mesenchymal stem cell. It becomes activated. It becomes a regenerative cell. And what does it do here? It does immune modulation, affecting our whole, basically, immune system. But it also stimulates the cells to start reproducing, producing other chemicals, etc. Are any risk with these cells? No. We've probably been 18,000 studies so far, and it's okay to use them. FDA says it's okay to use them as long as they're minimally manipulated. FDA rules, same day, same patient, same procedure, same facility with minimal manipulation. All right, how about growing them in the lab? Absolute no-no. FDA says can't do that because once you start growing these cells in the lab, you've now created a drug, and you now are under the auspices of the FDA for this. Now, how about hematopoietic stem cells? These are the real workers. Hematopoietic stem cells aren't just making blood and blood vessels and things. They actually, by the principle of plasticity, can go ahead and form other tissue. And we can see by that diagram here. They can actually start here, and they can go to bone, they can go to vascularity. They have this principle of plasticity, which is so important. Now, adipose tissue, believe it or not, your fat is a treasure trove of stem cells, okay? Now, we look at the sources of stem cells. We see the heart has 1 out of every 40,000 cells as a stem cell. Bone marrow, it's 1 out of every 100,000 in older age. Adipose is 1 out of every 100 cells. So fat is so important in the treatment of our musculoskeletal injuries. Now, look at what adipose can do. Pancreas, neurons, cartilage, liver, myocardium, bone, muscle. All these tissues can be derived from stem cells in your adipose tissue because they've done it in the lab. They've done it in studies, animal studies, etc. So that shows you how important adipose is. Is it the most important one? No, absolutely not, but it's an important one. Now, this is an interesting slide, but it's also somewhat deceptive. It shows a number of mesenchymal stem cells in fat versus that in bone marrow, okay? But this is not the total number of cells. This is only mesenchymal. So it's somewhat defective because when you look at the total number of cells, bone marrow is going to be up here. Bone marrow still has more stem cells total, but this is mesenchymal. Now, what are the methods of obtaining adipose cells? These are a couple different methods here. These first 3 methods, again, are kind of like a real gray area with the FDA. Actually, it's a black area. The FDA says you can't use them because it's more than minimal manipulation. Simple liposuction is a very simple, cost-effective, safe way of doing this, very inexpensive to do, and it works exceptionally well. Now, there's something out there, and you see a lot of this advertised, a lot of courses advertising it, for something called SVF, okay, where what we do is we'll take about 2 or 3 ounces of fat, we'll break it down with an enzyme, typically collagenase. Now, what happens is this will produce about 1 or 2 cc's of what we call stromal-vascular fraction, which is extremely rich in stem cells. However, this is a very gray area with the FDA because the FDA is really contending that when you do this, you're doing more than minimal manipulation. You're actually changing the nature of that tissue, and we think that probably within the next year there's going to be a ruling that the FDA says you cannot do this anymore in the United States. So just in case you want to get on and get some training in this, I would recommend against it because this thing is radioactive with the FDA. Now, SVF drawbacks. Well, okay, forget about the other things, what the FDA says. Basically, you're destroying the niche. You're throwing away a very important cell. Again, it's like a little, very small embryonic-like stem cell. And basically, these cells don't seem to do too well when you put them back in the body. So SVF is not really the answer we thought it was. It was the rage a few years ago, but it no longer is. Now, the FDA is thinking, again, this is what I'm just telling you. Right now, they said, we think that this is going to be. This is just a guidance right now. But once the guidance comes out, many times it'll become a ruling. And once it's a ruling, then you're breaking the law if you attempt to do this. But this is what we'll get from about 2 ounces of fat, just this little bit right here. So very potent. It's good for people that want to use it intravenously because it's so small. You would think, wait a minute, how can you put fat intravenously? But it's not fat anymore. It's just those the very small cells. Now, lipogyms is a technique we've been using from Italy. This is okay with the FDA. Basically, what we're doing here is we're getting fat and we're cleansing it. We're removing the oils and things like that, the impurities. And again, what's nice about the lipogyms, it preserves this niche for these periocytes or these mesenchymal stem cells, and it allows a much higher survivability rate, okay? The other purpose of the fat, it acts as a scaffold. It's a very inexpensive bio-scaffold, and it really seems to work very well. And I use it on all my cases. Everybody that I do gets at least 1 fat graft. Now, Muse cell is something that's found in fat. It's, again, pluripotent. It's like a very small embryonic-like stem cell. Very high survivable rate. Now, bone marrow stem cells, we use local anesthesia only. We find that that works exceptionally well for us. And you can see here by the diagram what we're doing is we're going down. But the problem you have when you're doing bone marrow, the Jamshidi needle is designed to take 1 or 2 cc's of aspirate, and from that point on, it's getting contaminated with whole blood because it depends on where you do the geography. In other words, if you keep changing the position where you're drawing that blood from, you're going to get a much higher yield. So there's a new product out now, and this is called the Marrow Solutions needle, and what this does is it makes use of the geography, okay? And that's what's good about it. So we can see here, look at the point here. See, this is no longer open in the bottom. It's now closed, so that gives us less contamination with the whole blood. And then we just keep changing the position because this needle can go up and up and up and up. So I'm taking 1 cc at a time, and the real beauty of this is I don't have to centrifuge my bone marrow. When you centrifuge, you throw away very important things. Again, we take advantage of the increased geography of the aspiration. Now, this is just a little test that we did. We went against the Hospital for Special Surgery, Dr. Lane and his group, and this is what they did on a very specific way of trying to get the highest concentrations of stem cells they could. And they centrifuged. And this is the colony forming units there versus us. Total colony forming units, we beat them substantially. Again, no centrifugation. Okay, now here's the problem with bone marrow, mesenchymal stem cells. As we age, goes way, way down. Now, bone marrow versus fat, the bottom line is you want to use both. Fat is good in mesenchymal, not so good in hematopoietic, so use both of them. It's very important, okay? Future target tissues, well, you may read about all these placenta stem cells. There's no such thing. FDA does not allow it. These are zombie cells. They are not living cells. When you use placenta growth factors, that's all you're using, placenta growth factors. The cells are not alive. They're not viable. They're like a zombie. They may move around a little bit, but they're not living, okay? Now, an exosome, okay? Exosomes are released from the cell when you have a multivascular body that fuses from the plasma membrane. Basically, very important in cell-to-cell signaling. Here's a little diagram. This was the old thinking of what a stem cell did. It produced these little biochemical markers, and they would just kind of roll into the system. Well, that's not what happened. What these things is, they were packaged, okay? The stem cell would package these with an exosome, and that's how it really works. The best way I can describe exosomes to you, it's basically like a FedEx system. Also, by the way, saliva is a very rich form of exosomes. That's why medicines that are absorbed sublingually work so well so quickly. But again, exosomes are like the body's FedEx system. It gets there on time, the right place when it's needed. Photomodulation, basically we use PRP, and stem cells, we use LED lights on all of these because it does produce what we call photoceuticals. And you can see just some of the things here. We produce interleukin-1, interleukin-2 antagonist. We get more exosomes. Really works exceptionally well. And this is a light that we happen to be using for that. Now, DC stimulation, very important. Micro DC stimulation. What does it do? It increases vascular endothelial growth factor, increases nitric oxide, which is one of the holy grails of stem cell therapy, increases ATP reduction, increases stem cell motility to the area. This is a brace that we use. This was similar to a brace that was the rage. Actually, it was developed in Baltimore here by Dr. Hungerford, the Bionicare brace. He and Dr. Brighton from University of Pennsylvania. But what this does is silver fibers here, and a little microvolt generator powered by a AAA battery. Works very, very well. We use a lot of this on our athletes. Now, stem cells versus PRP, low oxygen content, you want to use PRP. In more of a higher oxygen content. Stem cells go for low oxygen content. What must be avoided? Non-steroidal anti-inflammatories make no difference. You can give them the day of the procedure, not a problem. Alcohol diminishes stem cell output from the marrow, so you want to diminish that. Coumadin, Plavix, all those other things doesn't seem to make a bit of difference. It's not a problem for us at all. Now, what other things do we do? Well, hyperbaric oxygen. Guess what? Hyperbaric oxygen has nothing to do with oxygen. Basically, hyperbaric oxygen increases nitric oxide production, which increases stem cell motility from the bone marrow. And it's all, again, by nitric oxide. And this is from the work of Dr. Tom at the University of Pennsylvania. He showed this very succinctly. Nitric oxide, like I tell you, is one of the holy grails of stem cell therapy. It's getting increasingly more important in all forms of medicine. We know that nitric oxide is a very important signaling molecule. Extracorporeal shockwave therapy. Many years ago, those of us in orthopedics were using this for tennis elbow. We were using it for plantar fasciitis and getting good results. And then all of a sudden, insurance wouldn't pay for it anymore. But there's a lot of good science here. Basically, this works by increasing growth factors, cytokines, et cetera, increases microcirculation, and allows stem cells to home into the area. I do this more and more frequently on my cases, especially when I have a case that's a little more difficult, not getting to where I want them to be. We'll use this, and it works well. And we can just see here, again, angiogenesis, nitric oxide, vasculogenesis, et cetera. So very, very important. A lot of good science behind it, okay? And there we are there. Again, release of nitric oxide, growth factors, and vessel growth. Now, talk a little bit about cytokines. Every disease that we treat in medicine is an imbalance of cytokines. Osteoarthritis, imbalance of cytokines. Heart disease, imbalance of cytokines. Cancer, imbalance of cytokines. These are all related to that. Here's the beauty. This is what we want to do. When we use cytokines, we're basically using them in a physiologic concentration. And because we use it in a physiologic concentration, we essentially get no side effects. Most of our medicines are pharmacologic, get side effects. And if you get too high a concentration, you'll get toxic things. Now, here's some of the definitions. These are the cytokines. These are the dosages we're using, 10 to the minus 9, 10 to the minus 12. Talk about something being extremely powerful. Can't get much more powerful than that. Now, this is a slide that basically entails every facet of medicine. If you have your cytokines balanced, you're going to have health. If you have too much of certain ones, you have disease. Too little of certain ones, you have disease. So we use oral cytokines. They are absorbed sublingually. Remember, saliva is a very good form of exosomes, so we use it that way. It's a quantum leap in all regenerative medicine. This is just a case that I can show you. We had someone here who had a very severe avascular necrosis of his femoral condyle. He was told by a few different orthopedic surgeons he needed to have a knee replacement. You can see also he was starting to get demyelination of the articular cartilage here. So this is in 2008. He was treated with bone marrow, fat, and PRP. Came back to see me in 2011 because he twisted his knee. He was playing. This is a fellow who, by the way, was using crutches. He was an elevator repairman and couldn't work anymore. He twisted his knee in 2011, and he was playing tennis 5 days a week. So we got a new MRI, and we can see the difference, significant difference, totally asymptomatic. And this is a Major League Baseball player, had a Tommy John injury. He tore his ulnar collateral ligament right there. We treated him with bone marrow, PRP, and fat, and we can see how he healed up within, I think this was about 8 weeks or so. He was back playing in 3 months, so that's rather than 13 months. And with that, I'm going to end my talk and see if you have any questions. Any questions? A lot of material there. It took me many years. Yes, sir.
Sir, I'm from India. I'm a rheumatologist. So you had a practice in an area where endemic fluorosis is dominant. And all my cases, maybe 20 to 30,000 cases are suffering from fluorosis of the knee joint. And according to you, there is injection in the form of mesenchymal application into the joint to prevent a total knee replacement surgery. But I have a basic doubt, I don't know whether you agree with that or not. In a fluorotic joint, there is destruction of collateral ligaments, and also, though there is increased in density of the bone is soft. And do you think this injection of this mesenchymal cell or platelet-rich plasma is going to grow the cartilage inside? I have a basic doubt, sir.
Okay. Well, first of all, you're not just injecting mesenchymal stem cells. Mesenchymal stem cells are not going to do anything to get the joint better, other than do some immune modulation, okay? Because you're injecting a whole host of cells. You're not depending on mesenchymal alone. Now, we've had very good results. Stem cells will do two things. We have some patients where we see a significant change on the x-ray. They will actually have a space. Other patients, the x-ray will not change very much at all. However, the mesenchymal stem cells will change joint chemistry to then allow them to become asymptomatic. As orthopedic doctors, we all know, or rheumatologists, patients walk into our office, bone-on-bone arthritis, and have no symptoms. Why? Because they probably still have functioning stem cells. That's the whole thing. And I think that's what we have here. In some of these cases, yes, you have some ligamentous. I mean, if we have someone with a significant valgus or varus deformity, we're not going to correct that, okay? We can change the chemistry of the joint. They can feel better. We can put them in an unloader brace. That will help them quite a bit. But they're still going to have those deformities. But we're changing the chemistry of the joint and making them
so
relatively
we can
asymptomatic.
Use this. Very nice, sir.
Yes.
Thank you, sir.
Sure. Any other questions? Okay. Well, thank you so much.